This is Dr. Charles Parker, and you're listening to Core Brain Journal. It's a place where I connect both fresh discoveries and interesting different perspectives from advanced mind science with the realities of real people and everyday life down on Main Street.
Well, welcome, folks. It's Dr. Charles Parker here one more time at Core Brain Journal, and we have a different subject today, and we have Isaac Abraham, who's going to be presenting on a whole thing about hospitals and emergency rooms. Now, why are we even talking about that? You will find out if you stay with us. Hospitals, emergency rooms, as they say in the street, been there and done that, and it is a very, very significant problem around the United States. Isaac, thanks so much for joining us.
Thank you.
So, Isaac, why don't we start? Why would I be even excited about this? Why are you excited about it? Let's start before we even get into the subject of emergency rooms. Tell us a little bit about who you are as a person, where you are, your family, what you do, and then we'll get into the subject.
Okay. It started back when I was a mental health worker back in the early 70s, and I used to work with children and adolescents in a state psychiatric hospital. I fell in love with behavioral health at that time because I felt like that was my niche. And because that was my niche, I say, this is something I really want to do, during my lifetime. So I went to MCV School of Nursing, and after I graduated from there with my BSN degree, I went back to work also and worked in the same hospital because I really enjoyed working with the children and adolescents. I also went to the University of Virginia later on and got my master's degree in psychiatric nursing, because I really wanted to grow in this field, learn as much as I could. And another thing that I'm really interested in was teaching others. And I wanted them to understand that mental illness is truly is an illness. And that's the point that I really try to drive to people when I do work, no matter where they are or what we're doing. So after doing that, I became a nurse manager, assistant director of nursing, director of clinical services, on up the ladder. And then I began to take my talents that I feel I have out on the road. And I currently work for Compass Clinical Services out of Cincinnati, Ohio. I really enjoy what I do. I get to meet a lot of people, and I get to see a lot of things that's happening across this country.
Well, you got some great credentials. Hey, you're a Virginia guy. MCV, yeah, UVA, these great credentials. Now, are you a nurse practitioner then? Or are you a master's level nurse but not a nurse practitioner?
Yeah, I'm not a nurse practitioner. I'm a master prepared psychiatric nurse.
I got you. Well, you're in the club now, and you're right there in the street. You're not, you may be gone to UVA, but you're right there in the street is what's going on. So we look forward to talking to you. So why did I can see that you had an interest in it, but what were the difficulties that you found in terms of this next step in your life, dealing with the complexity of emergency rooms? I mean, it's a very, very challenging. Hey, I've been there. I know exactly what you're talking about, and I'm looking forward to hearing you tell more about it because I'm going to learn something from you tonight. So, how did you get into it? What made you drive toward the emergency room direction?
Well, as time went on, we began to have less and less resources in the community, and we really didn't have even some areas I go to, they don't even have enough beds to take care of the psychiatric patients, especially in some small rural areas. So that's what really got me, very interested in, again, wanting to take care of the psychiatric patients. One of the things I even experienced when I used to work in a hospital, I would go to the emergency room sometimes to assess patients, and the nurses would refer to the patients as your patient. And I try to get them to understand they're our patient. So, again, it was a double standard in my mind from experience of how the psychiatric mental health patients were treated versus the people who came in, for medical reasons. So that sort of really sparked my mind in being an advocate, for the group. I've always been a strong advocate for the mental health population, but this really did increase my motivation to want to do something to make their stay in the emergency department as bearable as they can be.
So then did you get I'm sorry, I interrupted you.
You can go ahead.
Well, your experience then was your training. You didn't really have a specific you kind of came into this like you're interested, you're a psychiatric professional, you got a master's degree in psychiatric nursing, you're a nurse, so you've had plenty of experience as a nurse, but then this whole thing of emergency room psychiatric nursing, that's a whole nother remarkably deep kettle of fish.
Yes, it is. And, and one of the things that, it became part of a national movement also, because when you start to read news articles and things like that, you realize it is happening all across the country, to the point that the Joint Commission and CMS, the regulation people, had to get involved and says, hey, we've got to do something about this boarding of patients in the emergency rooms. So when they got involved and it became part of the standards, and one of the things I do with Compass is I also go around and do mock surveys and things like that. So in doing mock surveys, I realized that it truly was, a real serious problem where people would stay in the emergency room, especially some of these psych patients, for not only hours at a time, but for days and days. I've even known when it first started, there were people who were staying in the emergency room up to 7 to 14 days or whatever. And so I felt that this is an area that we really need to do something about. And that's another thing that sort of made me very interested in doing my work with Compass and trying to help the EDs to see, what some of the issues are. And then after seeing those issues, thinking of some ways that we can do things different and better for the sake of psychiatric patients, as well as for the patients who are in the hospital who become impacted. And when there's a negative outcome with a psychiatric patient and they get out of control, that really impacts the patients who are there for medical reasons also.
So the ED is an emergency department, of course, that goes without saying. But tell us a little bit more about that, because it's news to me and I really didn't know about it. The credentialing group for emergency rooms, what was that group? You went by it pretty quickly and I didn't quite get it.
Okay, the Joint Commission.
Oh, the Joint Commission on Hospital.
Yeah.
Okay.
The Joint Commission and the CMS is the Medicaid people who also are federal discipline that looks out for patients also and have regulations and standards that we all have to abide by.
Well, what's CMS? What does CMS stand for?
CMS is just your Medicare, Medicaid, part of the federal government.
Oh, I got you.
They're paying for the bill for patients to be in hospitals. So, and I agree with them. The standards that they have set are basic standards that everyone feels that sometimes are a little tough, but to me, they're the basic things we should be doing with every patient in order to provide the best care. And when I go and work in hospitals throughout the country, the first thing I tell the staff is that we are not making these changes for the Joint Commission or CMS. We're making these changes because it's the right thing to do to take good care of our patients and give quality care.
Well, that sounds very honorable. Now let's get down to right there where you are with a staff member or a group of staff. What are like 2 or 3 of the most important things that need to be kind of the common denominator on everything you're talking about in the emergency room?
Okay. First of all, the number one, as far as, the medical process, the EDs with their leadership needs to make a commitment to wanting to provide the best care. And that means doing a real good assessment. If you don't do an assessment, you don't realize what some of the problems are. And you need to involve people from not only the CEO suite, but also the nurses, the staff, the people in transportation, everyone who's involved and touches that patient. And we found out in doing this, we found out that there's a lack of standardization a lot of times when they're working with mental health patients. There's a lack of resources, especially during peak times in the emergency department. The place I'm currently working at, they have tremendous peak times, and they have to, and they've put a system in place where they call for help. And people I'm working on the psych unit, we'll go down and help them, and we work together as a team, and that has made things much better, having more resources and people to work with you when you're having the most difficult time. And another big issue is the safety. Safety is always number one, And maintaining a safe environment is very, very, very important. And that's one of the things that most emergency departments have issues with. So they have to get security involved, extra staff involved. So one of the things I do also is that we do a lot of training, because when you work with people who come to your hospital with mental health issues, you have to be trained in how to work with them, because you, as a clinician, a physician, or whatever position you're in, you can really sometimes cause them to become agitated and out of control. So I enjoy doing that kind of training, and to also teaching them the signs and symptoms of when psychiatric patients are about to have an explosion and with behavior. And then the most important part, teaching the staff how to de-escalate these behaviors before they get out of control.
All right, let's take a moment, because we got some interested people here. They want to know what those signs and symptoms are that you can see the person's about ready to pop.
Okay. Well, for instance, a lot of times as patients come in, they'll show you some symptoms such as they're pacing, a lot of times, and that can be a symptom of they're becoming agitated. And another symptom that they have, they get to the point where they are extremely loud, and you can look at their affect. A lot of times when they come to the hospital, especially the emergency department, staff sometimes think their anger is because of them, but their anger is because someone brought them to the hospital. It could be a family member. They could have had a bad encounter with a police officer. So you have to look out for and realize that it's not you that they're angry with. So you need to be therapeutic, kind, quiet, watch your tone of voice, make sure that you don't challenge them. And this is one of the biggest areas that I see we have issues with. If a psychiatric patient is loud and sometimes and saying things that you don't want to hear, I've seen professionals, unfortunately, challenge them and become as loud as the psychiatric patient. So when you see that they're beginning to act out, then you need to do the opposite. You need to be calm. Sometimes if you have to, you can tell them, well, right now, I want you to settle yourself down, and I'll get back with you later, and not imposing yourself on them or forcing them to do things that they that they don't want to do at that moment. I know we have deadlines and we want to get things done, but sometimes it's better to take a minute to be safe than end up with a half an hour or an hour negative intervention.
Yeah, I got the picture in my mind of a negative intervention, and I'm sure a lot of us do. I mean, if you've worked at all in psych wards, state hospitals, and you've seen negative interventions, they can be terrible. So let's get another example. So those are a couple of quick ideas of things that you're talking about. How do you actually work with a emergency department staff in a rural hospital without any deep psychiatric backup? What do you recommend in that situation?
Well, one of the things that I've done, especially in small rural areas, I have been Compass have been hired to go to emergency departments and do the actual training. They're very competent in doing their medical piece, but a lot of times they need some education related to how to deal with the psychiatric patient. So I go there and I use to spend some time teaching those staff, and also I part of my teaching involving them being able to vent how they feel, and this really is real helpful to the staff.
Say that last thing you said. You were breaking up there. I'm sorry to interrupt you, Isaac. Say that last thing you were talking about.
Okay, the last thing I was talking about is how I involve the staff in the education piece by encouraging them to be open, honest, and I've had staff to say, Isaac, when someone curses at me, it really makes me angry. And then I would talk to them about understanding I'll give an example. I said, well, if I'm a diabetic and my blood sugar goes up to 600, would you get angry at me? They said, no way. I said, okay, well, think about when you have people with mental illness, especially those who are agitated. Their cursing at you is really a symptom of their illness, and try to get them to think that mental illness is something that, these patients cannot help and not choosing to have. So sometimes that helps them to understand that you have to be empathetic, caring and have compassion for not only the medical patients, but for all patients, and especially psychiatric patients who come to your emergency department.
So what you have staff, they may not be a psychiatrist, but you have staff that are going to be like, hey, I'm going to be your psychiatric person here, even though they're not specifically psychiatric trained like you are, but they need some kind of person that wants to be involved with that responsibility. Is that correct?
Yeah. Yes, that is correct. And we also, I went to one area in one state, and the physicians came to my training too, because they realized too they need to be able to help the staff when they're having difficult times. And I really appreciated, having them come to the training, and they wanted to learn too, how do you deal with psychiatric patients. And so that was very successful in the sense that the attendance was good, and they felt comfortable in attending the session. Also, the reality is now that there are psychiatric patients across mostly every area and every hospital now. So it is something that we are really encouraging people to do. Let's all, train your staff, and they won't be psychiatric nurses or doctors or mental health workers or CNAs, but they will be able to understand how to de-escalate patients and when to back off and not put themselves in dangerous positions. So that's part of the training that I think is essential, and a lot of hospitals are beginning to buy into that now. The current hospital I'm at, all the staff in the ED takes training, the same training for de-escalation techniques that the staff on the mental health unit takes also. And they work together. If they're having an issue in the emergency department, the psychiatric staff go down there and help them, and vice versa.
All right. So now, how do you get that patient out? Pardon me for interrupting you. How do you get that patient? I'm watching. I'm living with you in that moment in the ED with a psych patient, and you also know that it's counterproductive to keep that person there for 7 days, 14 days, and they aren't medicated properly. They aren't handling themselves. I say medication because that's one of the key ways you can bring somebody together who's out of it. But what do you do how do you plan for that transition? Where do you put them? What do you do? What's your recommendation?
Okay. Yeah, the recommendation is, first of all, when patients, after the physicians and the staff, if they do a good psychiatric assessment, then a lot of times, a lot of our patients do need medication, because one of the non-compliance is a big issue with psych patients. And when they come in, they haven't been taking their medication. And, the physicians in the ED are aware that they do need, some intervention when it comes to medication. But also, that's not all they need. They also need someone that they need a plan of care so that they're taken care of in the ED. You're responsible, and the regulators like Joint Commission and CMS, they are really putting standards out now which indicate you have to take care of the whole patient while they're just there. You just don't, put medication in them, restrain them or seclude them or whatever. You have to take care of that patient while they're, in your ED.
Yeah. Just like they're in a hospital bed. Yeah.
Right. Yeah. So, and that one time was, we were really hurting in doing that, because they really, it was the old saying that, you just give them that medication, put them to sleep, and then you don't have to deal with them. But they have to be taken care of, because if they have medical problems, issues, you have to deal with that. And that's one of the burdens of the emergency department when they have patients that are boarding for 7, 14 days or whatever. They really don't have the staff, to manage that extra 7 or 8 extra patients, that are staying in the ED for that long because of lack of resources in the community.
Wow. Go ahead. Let me interrupt and ask you. I want to mention one other quick thing, and that is Isaac Abraham. I want to thank you very much for what we're talking here on this PDF giveaway. Isaac has given our listeners a PDF giveaway, and I want to just take a moment to ask you about it. That's going to be available at corebrainjournal.com / 065 download, 065 download. And this PDF, the title that you've given me, and I want you to clarify it for our listeners, it's a hospital near-death experience, how Medicare termination can push your hospital to the brink of closing. So if people are interested in this, they're probably hospital people, and that would be a way to start to think about this whole business of possibly the hospital closing. Tell us a little bit about what that PDF carries with it, addresses.
Well, one thing that has to happen, in order to remain being a hospital that can function in whether you're in a rural area or city, state, a big city or whatever, compliance is what has to happen, as I said earlier, in order for you to stay open. We've worked with hospitals who have had final warnings from CMS, especially CMS, and they end up having what we call a SIA. And what will happen is if they don't pass the regulations, then their hospital will be closed by the CMS people. One of the things that's real worrisome about that is that now you have usually an area that we're lacking resources before, and now it's even worse. So, at CMS, they've had patients, they don't do it the first time. It takes probably about 3 visits where you're completely non-compliant before, you will lose your license and ability to take care of patients as a hospital facility. So it's very crucial. It's very crucial that everybody who works in a hospital, you make sure that they're really putting their best foot forward, again, for the right reason, to provide the best patient care that they can provide in order to keep their community strong and work together as a community. And that's one thing that I strongly recommend, too. The EDs and the hospitals cannot do everything by themselves, that you get together, the leaders of the community and leaders in the police or sheriff's department, and you sit down and you plan what you can do to prevent bad outcomes or things that are unsafe in these local hospitals, so that you will not lose them, and then a bad matter becomes worse.
Yeah, you've got other personnel there. Now, let me ask you this question. What is the biggest reason, and I'm sure we got some hospital people here who are thinking, hey, I don't want my hospital closed. What's the biggest reason that CMS would close a hospital? What are some of the most important problems that you've seen or heard about in your business that could close a hospital?
Well, when it comes to the Hazy Health specifically, or any area really, if you are not treating the patient in a safe manner, safe is so important that they be treated in a safe manner. And, some hospitals, unfortunately, have had some real bad outcomes, such as people even dying in their facilities because they're not compliant, following rules and standards and regulations. And that is real serious. And then you leave them no choice. As I said earlier, CMS is not going out here looking to close people, because they realize that we need these hospitals to take care of our patient populations in our cities and in our counties. So they're not looking to do that, but you leave them no choice sometimes. If they come in, give you an action plan, they say, this is what you need to correct, and then they come back a second time and you haven't corrected it, and then you'll get what we call, again, a SIA, and they will at some point have to make the decision to not let you operate because you're having too many bad outcomes, which has been negative on the population that live in your city or town, and you leave them no choice. So
okay, I've got the big picture there. Let me interrupt you because I'm still trying to take you down. I want to help you put our nose right there in the fire. Give us a firm example of what could happen that you have maybe experienced or that you know about that would really make it a near hospital closure.
Okay, well, all right. For instance, patients dying in restraint. That's a big one.
So restraints are a big one. They put them in restraints, and how do they die? They don't feed them. They don't give them. What happens?
Okay. Well, the number one cause I found, because one of the biggest things you find is that they're not monitoring the patient. And another thing that can happen that people don't realize, when I was running facilities, I did not use the 5-point restraints because I did not believe in tying their chest down. I went to a place that had some real bad outcomes, and we had to turn the place around because they had several people die from being in restraints because of those 5-point restraints.
Stop right
So
there. Stop right there. Now let's talk about, I've done restraints back when I was a kid. I don't do restraints anymore because I'm a straight outpatient, but there are a lot of people out there that don't know what a 5-point restraint is. Let's break that down.
Okay. This is when you literally usually level restraints. You tie down, the 5 points are both legs, both arms, and the chest, a strap that goes across their chest, and you tie them onto a bed, and they cannot get out of it. And with the leather restraint, it's, the patient cannot get out of that, and they're struggling a lot of times trying to get out. And sometimes I was involved in a couple of cases where they end up having heart attacks because they had medical problems, and their medical problems were not assessed properly back then. So that's a major cause. And a lot of times that can be a legitimate reason for CMS saying that, you're not a safe place to take care of patients, and they would close the hospital down because of that poor patient care.
All right. Also sounds, pardon me for interrupting you, because I'm bringing my own personal experience in on this, but it also sounds like that hospital doesn't know how to use chemical restraints. They don't know how to take them down in a way that's going to be constructive and helpful. I mean, right. Well, is that true?
Yeah, you're correct. Yeah, that is true. And then you have sometimes the overuse of chemical restraints also. And you have to be, you have to make a good assessment of the patient. And what happens in the same facility, they were using such heavy doses of chemical restraints that it became problematic. And between the chemical restraints and the patients were not acting out once they got the chemical restraints, but they still had them strapped to the bed in those 5-point restraints. And that combination sometimes is not a good combination, especially if someone has cardiac problems or, respiratory problems and things like that. So that's what happened at one place I used to work at years ago.
Well, yeah, if you got that restraint on their chest and they can't breathe, and you got all kinds of other things going on, yeah, it sure does sound like a potential catastrophe.
Yeah, and also the staffing, and the mental health counselors were the ones who were left you have to monitor the patients. So it was the mental health counselors who were left to monitor those patients when they had, long times of being restrained, had, a lot of chemical restraints put on board. And that was part of the problem also, because they could not assess the patient or realize that the patient was even in danger. So one of the places that I did work, my rule is a nurse had to sit 1-to-1 with patients who were, if they were restrained to a bed. And I tell you, the good thing about that, when I implemented that, the restraint went down to almost nothing, because for some reason the nurses found other ways to deal with it.
Right. It makes total sense, doesn't it?
Yeah,
if you can tie them up, you can forget them. That doesn't make any sense.
No, that doesn't make any sense.
Oh my gosh, it's a terrible situation. So we're running out of time here, but let me just ask you this. So what would you think that people should do? First of all, do you have a message to our listeners? Those of our listeners that have selected to look at, hospital, emergency department, psych things. They're with us on this. They're going to download that piece. But what would you say would be the big message that would be the most important next step that people need to take to get themselves covered so they don't have problems in their hospital, in the emergency room?
Okay. Step number one, get together with all with the administration, the staff that work on the unit, and start saying, hey, we want to do something about this, and making an effort that you involve as many people as you can at every level, because believe it or not, everybody has input. So you want a well-prepared ED when they come into your emergency department. And that means that you have thought things out. You thought about what happens if a patient comes in and begin to act out. You know what we do if we have a patient who's a high suicide risk. And you also, what we do at the place I'm at now, we call a cold help. And if people come down from all the other areas in the hospital, and we all work together and make a plan to make things easier for the emergency room staff, but also to take good care of the patient. So it's also, you got to concentrate on the most second important thing is improving care and safety. And this is one of the big things that we have to do. All the staff should be trained in de-escalation of dangerous behaviors, because if you don't do that, you can get caught into the behavior of the patient, and you increase their stimulation and sometimes keep them going if you don't know how to de-escalate patients. Now, it's not going to be 100%, but we have found out, in my experience, have been the more you're trained in de-escalation, and again, you have to take a deep look at yourself as a practitioner, no matter if you're a doctor, nurse, mental health worker, CNA, or whatever, that you have to realize that I'm going to do the best I can to maintain my calmness so I can help the patient remain calm. Gotcha. And people will say that stuff never works, but it really does work because I have experienced it. And again, a good assessment of the psych patient, I think, is something that has to happen. And sometimes you need to have some training for that, because sometimes in doing a good assessment, all psych patients who present they could have delirium or something like that, or they could have a medical thing that's making them irritable or whatever. You just can't skate over them. You need to make sure that you're doing a very good assessment and meet their needs wherever they are. And psych patients have told me, a lot of them, one of their biggest concerns is that no one ever listens to us. Now, I've heard that for years. And sometimes my favorite saying, 5 minutes of talking can prevent you from having an hour of an event that's
so true. Goes out of control. So absolutely true. We've seen it happen many times. Now, let me ask you, and this isn't a pharmaceutical hookup drug question. I'm just going to ask you, one medical professional to another. What do you recommend most of the folks use for severe agitation in the emergency room? Do you like the benzos? Do you like Haldol? What is the how do you choose that, and what do you think about that?
Well, I can tell you what they're going to get. They're going to get, Haldol and Ativan, because when I go to places I've reviewed, that's together. They're going to get the Haldol, Ativan, because it works real fast, and but also that's for people who are extremely agitated. But unfortunately, I feel personally that we use it a lot more than we need to, because if they begin to even show signs of agitation, then we want to start with that. But there are other medications you can use that can calm them down, but you got to catch them early. You can't wait till they've been sitting in the emergency room 4 hours and then expect them to not escalate. So, but I'm telling you, that's just, people will tell you, that's their those drugs of choice, the Haldol and the Ativan.
All right. Well, this is great. I really appreciate you taking the time, and we're not going to leave it at just Haldol and Ativan. I mean, that's kind of misses the whole point if we do that, but I just thought that'd be a point of curiosity, because people were wondering, what do you do chemically? And we hit the 5-point restraint, very good point. We hit the idea of planning to get them out of the emergency room and have a plan for where they're going to go and de-escalation. So we want to really thank you for pulling all this together for us. Isaac, it's been a great heads up on a reality that very, very few people actually deal with every day, unless you're living in that emergency room day in and day out. I mean, it's the way it is. We see it in psych hospital, but you got to be on that psych unit, on the most difficult unit, whatever that happens to be called in whatever hospital, to really understand what's going on with psychiatric patients who are acutely disturbed. It's a big deal.
You really do.
So listen, where should we go? What's your website for people to get more information on this and think about possibly educating their staff to get the latest and greatest on how to do these interventions? Well,
Compass Clinical Services, and we're located, there's a lot of places called Compass, but we're the Compass Clinical Services, and we're located in Cincinnati, Ohio.
Cincinnati, right out there in
Cincinnati, Ohio. Yep.
All right, I'm looking at your thing here. We'll put the link up for everybody. So it's called compass-clinical.com.
Yeah.
Compass-clinical.com, and they've got staff training and behavioral links. They've got a plan of care links. They've got a lot of things you can download there, folks, and And so I think it's certainly useful to have this discussion. It's not for everybody, that's for sure. But there are a number of individuals who have to deal with this every day, and I really appreciate you taking the time, Isaac. It's been great.
Yeah, and thank you, and I enjoyed talking to you. And Compass truly is a company that cares. So, I'm putting it up pitch for them because we really do care,
Thank you. It sure sounds like it. I really appreciate it.
All right, thank you too.
Thanks for listening to Core Brain Journal. We're working every day behind the scenes to bring you reports that connect research benches with those street trenches. Here we share the complexity of mind science because, as you know, details really do matter. One of the most pervasive, misunderstood challenges is how commonplace medications, like those written for ADHD, are used so regularly without clear guidelines. If you think you'd like more specifics, take a minute to download my 2-page PDF packed with video links and references on the absolute essentials of how to start ADHD medications. They're easily available at corebrainjournal.com/start. Thanks for listening. Do connect and stay tuned. Together we can make a difference.